All right, everybody, we're live. You did not get intro music today because I'm the one operating everything today, and I'm basically a moron when it comes to this stuff. So Jay usually does all the clicky things, and I just show up and talk. So you didn't get any intro music today, but with me is Dr. Mike Stair. Mike is a longtime returning guest. He is a fellowship-trained physical therapist, a physical therapy educator, a personal trainer, and nutritionist in the Boston area. He's the owner of Orthopedics Plus Physical Therapy and Spectrum Fitness Consulting. And he was not with us last week because he was out doing like actual educational things, if I'm correct.
Yes. Cedar Rapids from a distance. So yeah.
Oh, okay. I was like, yeah, did you travel all the way down there? Or you just, your face was just very big on a screen somewhere?
Exactly. That's the extent of my travel right now.
Hasn't it been kind of nice this year? Like just basically no travel?
Yeah, I have calculated that I spend 36 days cumulatively a year of being gone. So yeah, but be honest, I do kind of miss going into a hotel,
Yeah.
having my own space. I love it for like 1 or 2 days, and then after
Yeah.
that, I get homesick. But
Yeah.
so it's been a mixed blessing. But yeah.
Yeah, I know. I think like the last couple of years, I think I've probably been gone somewhere in the neighborhood of like 2 to 3 months cumulatively every year. And so
Yeah.
it's just so nice. It's been like, hey, no planes, no travel. It's been pretty awesome.
Yep.
But awesome. Well, we've got a couple core related, back related topics to discuss today. And I think we'll start with the big one is does spine flexion contribute to back problems? So I guess the first question is like, where did that idea / myth come from? And I think we've like heard it everywhere from like, don't do crunches because it's bad on your back. Don't deadlift with a rounded back, and everything's kind of like keep your back neutral or straight. So like kind of like where did that idea start and what's the evidence around it?
Yeah, it's I think one qualifier before we talk about that, one source of confusion for a lot of people when we talk about is this good for back pain or not? We have to appreciate that back pain is not universal. There
Yeah.
are so many different types of things that we're talking about when we talk about back pain. The experience of a 67-year-old with back pain is often markedly different than that of a 25-year-old lifter that's laid up after a rough outing of deadlifts. So we have to keep that in mind when we look at the literature, that back pain is inherently a heterogeneous, population. It's kind of like, are books good for people? It's like, well, what books are we talking about and which people are we talking about? So where did that whole flexion thing is bad get started from? I think it's based on two things: simple observational issues. When people throw out their back, as they often refer to it as, it usually involves a bending or twisting motion. So the logic is that, well, since I bent and twisted and that hurt my back, then that's bad for my back. I think some of the most interesting rationales for why bending should be minimized, or we should at least be concerned about it, is with the popularity of McGill's book that came out, I believe, in the early 2000s. Stuart McGill is a biomechanics researcher from Canada. He has been very, very prolific in accumulating evidence, mostly on cadaver spines of pig spines, because they're pretty analogous to human spines, and exposed them to various cycles of stress and load. That combined with evidence that he found, there is convincing evidence that with repetitive cycles of flexion, the vertebrae will actually fail. And in turn, there's a mechanism by which the disc will fail.
So that's interesting. And I'm going to pull up, just since we're talking about it, just a picture of the spine so people can kind of see just like what it's supposed to look like too. That it does kind of have natural curves in it.
Mm-hmm.
But so that's interesting. And this is one of the things that I actually ran into in my doctoral work. Not pig spines, but that's the same kind of concept. Is it would be interesting to me that he would choose that as a model when pig spines are not loaded like top to bottom. It's a completely different loading pattern. So was there any like discussion or thought around like, hey, I'm taking an animal that's oriented horizontally and comparing it to an animal that's that's evolved to load vertically.
Right. I think, first of all, he used a cervical spine of pigs, seems to have more of a structural analog to the lumbar spine of humans. And when he was observing them, he made them vertical. So he put them in a model that actually took the spine vertical. So I think it was more of the not the functional requirements of the spine, but more so the anatomical similarities that was the reason why the pigs were chosen.
Okay. And so then how is that kind of translated to actual, like, in humans, what do we know about injury, and then how does that relate to kind of spine curvature and all those things?
Yeah, so with the loading models, it gave the theory that there is a limited amount of cycles of load, meaning that eventually, when you subject a lumbar spine to repeated cycles of load, there'll be tissue failure. Now, of course, there's the inherent problem of what's called in vitro versus in vivo. We're not seeing a live model. For obvious reasons. I don't think you're going to have a lot of volunteers that will
No.
allow their spine real time to be exposed to that. And because of that, you don't have the dynamic nature of all the tissues surrounding the spine and the remodeling capacities of the spine. But nonetheless, it gave some credence to the idea that maybe there is a limit to which, if we continue to repeatedly load the spine in flexion or flex the spine, there's eventually a failure point. And I think that's still a plausible notion. I think the problem is people have taken that logic and assumed that, well, my spine has a certain a certain budget, so to speak, a certain amount of cycles that I need to minimize the amount of flexion I do, because eventually it's going to wear it out and then it's going to fail. And I think this is where the application comes into play. If you have a healthy spine and you're not under high amounts of load, or you're not going through very large cycles of loading, meaning that you're not exposing it to just a little flexion here, but excessive flexion over long periods of time, there's probably an expectation for perfectly fine tolerance to that. And I think that's where people are having problems. They're extrapolating the limitations that if you have a known structural damage of the spine, you're very symptomatic. It's pretty clear that you should minimize or avoid cycles of flexion, at least for the short term and perhaps the long term. But if you have no known history of it, there doesn't seem to be any evidence or logic that you will be exposing your back to significant risk if you expose yourself to bending of the spine.
So in terms of, I guess, a couple questions. One is, for most people who have, like, let's say, low back injuries, generally is the main mechanism, is it bending? Is it twisting? And then does it really have anything to do with, like, the amount of load that you're carrying? Because I just think about, like, my own anecdotal, um, you know, the times that I've, like, had a back spasm or done something to my back. It's always been like bending down to pick up a shoe, warming up, like getting out of the car and like grabbing a suitcase where I've been sitting for a long time. And I've never injured it when it's been like a super heavy lift or anything like that. It's always just been something super light and innocuous. So kind of what's, for most people who kind of have low back injuries, what's generally the main mechanism of injury?
Well, for most people that are south of 65, maybe even 60 years old, because the mechanism of having a initial disc injury when you're older is incredibly low. The reason being is that the analogy I give is that when you're younger, your discs are like car tires, well inflated. They can go over bumps quite well, take turns, but you might want to watch out for some nails or glass, right? When you're older, your discs are more like tractor tires. They're dense and thick. They don't absorb load very well, but you can go over some nails and some glass. The reason being is that as you get older, the annulus thickens. It becomes much more harder. the disc material becomes less likely it gets reabsorbed. So it's pretty rare to herniate a disc, frankly, when you're older. So therefore, they tend to be relatively tolerant of flexion. In fact, many of them prefer flexion. So talking about a younger population, yes, flexion, rotation, and combination usually are the thing that will spur the onset of a back issue. But again, getting into an analogy with that, I look at it like a car that's teetering on the edge of a cliff. And then some wind comes and sends the car careening over the edge. You don't blame the wind. You
Yep.
blame, well, why the heck did the car get in that position in the first place? So it's the straw that broke the camel's back, usually. So yes, the bending and twisting is certainly a component of that, because the posterior and lateral aspects of the disc tend to be relatively weaker. As well, the intervertebral margins of the disc, or I'm sorry, of the vertebrae, tend to be a little bit more vulnerable in flexion positions. And the posterior aspects of the disc, the facet or the vertebrae, the facet joints, tend to be more vulnerable to rotation, like a golf swing, for example. So what will set this off? It's not just those positions, but rather, and you mentioned some of them, a lot of people talk about the weight or the load. I think it's better to talk about torque. And I know it sounds like geeky physics stuff, but here's a simple way to describe it. Many of my patients have been told by physicians, by whomever, don't lift more than a certain amount of weight. And it doesn't make any sense. 10 pounds, 12 pounds, some arbitrary number. You give me 10 pounds and you have a huge back problem, and you hold that 10 pounds out like this, that's not going to feel like 10 pounds. That's going to feel like a lot of stress. You hold it here, you'll probably be fine. So I think it's not so much the weight, but the distance the weight is from the axis of rotation of your spine. So essentially, how far is the weight away? So that's one thing, in addition to flexion and rotation. The other is the speed. How quickly is the load being applied? So if it's slow versus very, very powerful, the impulse or the speed tends to be a factor. The time in which the flexion rotation happens. So first thing in the morning, the disc tends to be less tolerant to pressure because it's more pressurized from having a prolonged period of time without any load.
Mm-hmm.
Some studies have shown that it takes about 2 hours of being relatively upright for the intervertebral disc pressure to normalize. So that would say that you're more vulnerable to flexion and twisting in the first couple of hours in the morning. And finally, you mentioned this, it's in relative to what you've previously been doing. So for example, if you're a truck driver and you have to unload cargo, your back is more vulnerable in those few minutes after you got out of being in a prolonged sitting position for a while. So the reality is it's all those things. Sure, the end factor, bending and twisting, is required, but it's usually the cumulative nature of loads or stress that have happened over months, weeks, maybe even years, combined with the relatively short-term issues. The distance the load is placed, the speed by which the load is being brought up by the movement, when it's happening in the time of day, and then when it's happening relative to prior activities.
So those things kind of talk a little bit about the like structural disc things. What about some of the things that, a lot of us will get, like low back spasms, kind of the muscular things? Are those related to like spine flexion? Are those independent? Kind of generally, what causes those compared to like a disc problem?
Yeah, so they may be directly related to the disc problem. They may have nothing to do with it. Spasming is a hyperreflexive guarding phenomenon when it comes to the postural muscles in the spine. So that means it's doing that to protect a perceived threat. And that threat may be a well-known structural problem that, due to inflammation, due to some type of noxious stimuli, the muscles will guard and protect. So many people think that muscle spasm is a pathology in and of itself, and thus needs to be treated with a muscle relaxant.
Hmm.
That's kind of an outdated logic. It's like blaming the cops for when there's a bad neighborhood and they respond. They're there for a reason. So the problem isn't necessarily the response. So that's usually one thing. The other scenario can be a learned response subconsciously. Uh, the brain has assumed or experienced repeated pain or noxious stimuli with a certain motion. So the nervous system gets tuned up and anticipates a potential risk. So therefore, it will guard. Another proposed mechanism is instability. There's some debate about the use of that term, but when there's excessive mobility, usually in shear force at the spine, reflexive guarding may be a overreactive response. So those seem to be why muscle spasms are happening. It may or may not be directly related to a disc issue.
Okay. And so I guess a couple follow-up questions. So from like a treatment perspective, like let's say you have somebody who has a disc problem, whether it's a herniated disc or something like that. Like what is, I know there's surgical interventions, I know there's non-surgical, kind of what is your thought process around like, hey, how do I treat somebody who has, like a herniated disc or something along those lines?
Well, we have to start by even questioning and even maybe even referring to it as a herniated disc or bulged disc. The prevalence of herniated discs in asymptomatic people is relatively high.
Yeah.
So what I tend to what I try to use terms are intolerance to flexion or intolerance to load or intolerance to position or intolerance to tension. That gets us away from having to blame structures that may or may not be related to the problem.
Because that must be I don't mean to interrupt you, but that
Yeah,
must
no,
be like
please.
a diagnostic nightmare, right? Like if like I don't know the exact numbers, but I think it's somewhere in the neighborhood of like 30 to 50% of adult people over a certain age, like on an MRI, show a herniated disc with no symptoms.
Right.
So how do you, I guess, yeah, there's like, how do you diagnose something as a structural problem when you like the false positive rate and the false negative rates are so high?
Well, diagnosis is only good if it helps facilitate treatment and prognosis.
Yeah.
So, what do we know about back pain? We know that, and we know very clearly that rest makes the prognosis worse. We know that having a hypervigilance on anatomical treatments makes it worse. So, I mean, by even discussing, that you have a slipped disc, for example, there's even some evidence that when people know the results of the MRI, their prognosis is worse. Um, so I think the other thing we know is that movement is very helpful. Exercise is incredibly helpful, and the evidence on that is not even debatable. It's a very effective thing. We know that pain education is helpful. Um, Everything else, we don't have strong evidence. Injections, fusions, disectomies are all relatively weak evidence. Even specific types of exercise, using motor control training, using isolation approaches or general exercise, we don't have excellent evidence showing that one's better than the other. So that might seem very confusing, but I think here's how I look at a diagnosis with somebody. Can we define the positions, the postures, the movements, the tension, the load that contributes to your pain? And if we can come up with a very, very clear strategy about what will likely resolve their symptoms and then prevent this from happening. Do you think it'd be helpful to give like a specific example of a patient?
Yeah, like a case study would be awesome.
Okay, so this is the most common presentation of a case study of somebody who is an active exerciser, south of 60, and might be their first time presenting to a clinician for back pain. 90% of the time, they have had some familiarity with the symptoms they're presenting with, but this
Mm-hmm.
time it's really bad. Like they didn't go to work, they're missing time in the gym, and they're scared. They're like, they can now walk, they can now move. They're having a hard time putting their shoes on. Getting out of bed is like they have to think about it for a few minutes. Getting off the toilet is an adventure. Once they get moving day to day, they can get through most of their day, but they have to think about how they're putting their socks on. They are not sure if they should be going to the gym, or and they're definitely not lifting their kids or doing any yard work. On exam, I will typically find that they're reticent to do any bending. Extending back, however, is fine. Twisting, usually to one side, is more limited to another. They may have symptoms shooting down the leg, which gets them pretty worried. When they try to bend and extend their leg out, one leg in particular is less than another. They may think that they have a tight hamstring, and they're wondering, should I stretch it? So on exam, I'd say about 70% of the time, I don't find that there's any what I call neural findings, meaning that the reflexes are fine, their sensation is fine, and their motor function of anything below their knee is fine. Those are pretty strong indicators that the nerve root is not being compromised. And that's the first very positive thing I tell most of my patients. If I do see some problems there, I monitor that, because if that changes, that is a quick and urgent phone call to a neurosurgeon.
Yeah.
I count on one hand the amount of times that has happened in my career, but it does happen, and it's something you have to be vigilant for. After that, then we end up finding that now we've concluded that certain positions provoke their back pain. I then will try to deload them, whether they're in their position that they're having more pain. So for example, some people are so sensitive that even when they lay down, their back is sore. But when they bend their knees and put their feet up, like if you lay down on your floor and put your feet on the ottoman, oh, that feels better.
Yeah.
But they straighten out their legs so they're fully flat, that's worse. That simply is known to either increase or decrease the pressure on the disc. So now I know they're load sensitive. Or they're standing up, they're in pain, but immediately when they lay down, the pain goes away. That's another indicator that they're clearly load sensitive. Also, I'll do traction. I'll put them in a position where they're slightly symptomatic. I'll do a little traction, immediate relief from pain. Clearly, they're load sensitive and they're flexion sensitive. So right then and there, I can give them a myriad of different recommendations for what to do, what not to do, and I know what to start for treatment. I don't care if they have facet arthropathy. I don't care if they have stenosis. I don't care if they have retrosthesis of the L4 and L5. None of that matters, because I know that when they bend, they twist under load, it makes their pain worse. And I tell them, it's like, to make it real simple, it's like when you break your foot. If you sprain your ankle and I bend your ankle to the inside and I put a lot of load on, it's going to hurt.
Yeah.
Well, let's protect that. That doesn't mean that
let's not do that.
Right. But unfortunately, people are told don't do anything then.
Yeah.
So then I have to tell them a few specific things what not to do, and then tell them, but you can do this. For example, my patients are blown away when I tell them they can do lunges. Like, I can't put my shoes on. How can I do lunges? I said, well, you can deload with your hands, and you can keep your spine in a neutral position that's not irritating. So therefore, you probably be able to tolerate the motion fine. I give them a list of exercises that will less likely aggravate their back, and a handful of movements that they shouldn't do. For example, don't sit with your feet on an ottoman, while you're watching Netflix. That puts you in a flexion loaded and tension sensitive position. Clearly you're not ready for that. When you go to watch TV tonight, lay on your back, put 2 pillows underneath your knee.
Yeah.
And do that. It's remarkably simple. Unfortunately, it's made so complex by what you just mentioned, the perceived need to know exactly which anatomical tissue is at fault. And just to give one more key thing on that, if we were so focused on knowing that it's a disc or a facet or whatever, right now we have very accurate ways to go in and remove those structures or modify those structures, and it doesn't work very well. The outcomes are horrible. So we have to dismiss this pure anatomical view of the spine. It doesn't mean that we don't look at those factors at all. I mean, my undergraduate degree is in biomechanics. We certainly consider it. But it doesn't drive the entirety of our treatment approach.
Yeah, that's super interesting. I know that I've had, excuse me, I'm about to cough. Like, playing sports, I've had, banged up shoulders and knees and backs and all those things. And I've always, and maybe this was just the naive, like, I don't want to know perspective of being young and in your 20s, but I always avoided imaging whenever I could. The only times I went in was like when I knew I had like broken ribs. I was like, okay, I can feel them sticking out. I should probably get an X-ray.
Yeah,
And then when I broke my leg and I was like, I've sprained my ankle a million times. This is definitely a break. I need to go like get an X-ray to make sure I don't need like screws or pins or something like that.
absolutely.
But yeah, so it's like every time I've always had some sort of bang up injury like that, I've always avoided imaging and just been like, hey, I'll just go to the physical therapist for, 6-8 weeks and see if I'm getting better. And if it gets better, great. If not, then I'll consider like going to get something done.
Yeah, the imaging should always drive what you're going to do based on what what their finding is.
Yeah.
If you have an ankle fracture and there's a displaced fracture, you may not need it to be reduced and fixated. That treatment's going to be markedly different than if you find there isn't one.
Yeah.
So if you go in and you find that there is a frank disc herniation putting on a nerve, there is no evidence that that's an immediate sign that you need an intervention.
Yeah.
And as we mentioned earlier, it not only doesn't not change the acute treatment, but it may have been there prior to having any symptoms.
So in terms of, I guess like two different pieces to this. In terms of like prevention of like low back injuries, let's say, like what are the things that we can do from like a day-to-day perspective to minimize risk? Like I know there's no way to prevent it, but like what are some of the ways to reduce the average person's risk?
Yeah, there's pretty strong evidence on this. It's to avoid prolonged postures. And many people take that to think, well, so which chair should I get? Or,
Yeah.
they want to spend, money on it and whatever. I discourage people from looking at that option. Some people will take that then and say, oh, well, so you mean sitting's bad, so I'll stand all day long. That's not what the evidence shows on that either. Instead, changing postures, changing them frequently. How frequently? We have some decent evidence, it's not great, that suggests that prolonged sitting for longer than bouts of 30 minutes is unhealthy. So what happens if you're somebody like me who gets locked in? You're probably the same way, Brad. Like, you start reading something and then you look up, it's like all of a sudden it's dark out,
Yeah.
the lights aren't on in the house and you haven't moved in a few hours. And I see you doing this while we're even talking, and I do the same, is just deloading, just these simple acts of changing pressure. One of the theories or mechanisms why this helps is that it helps improve nutrient exchange and the fluid dynamics of the structures of the disc. Simply, it could be a desensitization of the nerve to one prolonged position. Who knows? But that would be the first recommendation I would give. The second is regular exercise. I know that sounds such a trite recommendation, but we just see it over and over and over. The correlates, the interventional studies, all of them keep showing that regular exercise, and it's from a variety of different types. Strengthening. There's decent evidence on Pilates, which is essentially a type of strengthening. Aerobic conditioning, those are all correlates with it as well. So that, and then a third thing is not to have, I'm trying to not use a scientific phrase, but what's called fear avoidance behaviors. Being super fearful or apprehensive of movement. I can't ever do this because I have back pain. I can never squat because I have back pain, or I should never do XYZ because of back pain. Now, there's extremes where that's true, but in general, that correlates very strongly to a risk of chronic back problems, ironically. So,
And is that due to like, let's say you have, some issue that's causing the back pain, and maybe it's like weak muscles around an area or something like that. and you just continue to avoid that, you just exacerbate that problem. Is that a little bit related to why like avoiding something can just make it worse?
Yeah, that could be part of it. The other part can be there's some decent evidence that catastrophizing or kinesiophobia is sometimes the other related term, can actually make you more sensitive to pain. So they've done studies where they told people, we're going to give you a stimulus. Now, this stimulus is going to be very, very painful. So, when you feel this stimulus, I want you to rate how painful it's going to be. And then they've done the exact same stimulus to another group of people where they said, this is a harmless, meaningless, stimulus. It'll cause, minimal discomfort. We want you to rate how much pain it is. Just preconditioning that had well determined neurological responses. It was not just that they rated it more, they actually saw the descending nerve firing rates of people that were preconditioned to pain or expecting pain had a stronger neurological reaction. That also goes to a related thing we talked about earlier. Many people clinicians have seen the evidence and research and said, you know what, I get it. The MRI probably isn't going to make our treatment change at all. It's not probably going to show anything that's going to give us any clinical meaning, but I just want to appease my patient. Maybe I'll just let them feel better. The evidence shows it does the opposite. It doesn't make them feel better. Sometimes it actually makes them feel worse. So those are related issues, and I think that's or at least the proposed mechanisms why.
That's interesting. So in terms of so on the kind of recovery side, like if you let's say you're talking to a large audience of people and it's like, hey, here's some of the things that are pretty common amongst all people who come into my clinic on the recovery road. Is it mostly like, hey, you got to get moving? What are some other just like general things you can kind of, I know it's really hard to generalize because everybody's different, but some of those just like basic, very easy principles.
Yeah, you got to get moving, and the moving should specifically allow you to do critical core functions. Getting on and off the ground, getting on and off a chair, pushing, pulling, and stabilizing. Because not only do you need to do the moving for the physiological effects, the stability, the strength, the nutrient exchange, but more so for the neurological effects, and specifically proprioception. So in fancy terms, we want them to start relearning how to put their body in strong positions. Mm-hmm. We see this with people with ankle sprains. Take somebody who is 4 weeks out of an ankle sprain. They're able to walk normally. They're considering going back to playing basketball, running. Ask them to stand on one leg and close their eyes. On the involved side, their ability to stay upright will be markedly impaired compared to the good side. Proprioception is the ability to perceive what position you are in space based on feedback from the joints. I have seen this, and there's a decent amount of evidence showing that many people with injuries of the spine also suffer proprioceptive damage, meaning that they can't tell whether their spine is in a flexed, rotated, or neutral position, which may matter when they are on the road to recovery and they're hesitant to lift or they're hesitant to move certain ways. Maybe if they were to lift or move in positions where they felt stronger, they would be less likely to have problems. So for example, you're 4 weeks out of an acute back injury. You're still sensitive to bending. So if we taught them how to do a squat, they'd say, no, I can't squat because every time I squat, it hurts my back. Well, let's try doing it without bending so much from your back and make the bend occur more at your spine or at your hips. They might now realize, wait a minute, that actually feels fine. So I encourage them to challenge these movements. And if they feel pain, explore their margins of pain. Well, I can squat, but if I bend, it hurts too much. If I hyperextend, it hurts too much. If I'm here, I feel fine. I use the wrist as an analogy a lot because a lot of people, I think, identify with that. Or when I do push-ups, it aggravates my back. Well, that might be because you're hyperextending. See what happens if you find a more neutral position, and now you can do a push-up. So I asked them to explore movements, not just because it's good for your general health, but it might actually specifically help you learn a lot about your unique back issue.
So kind of segueing into the next topic, because we just talked about this a little bit. What are, we hear a lot about like core exercises. I guess like what is your core?
Yeah.
Is that from like your chin to your hips, or like what is your core, and then kind of what defines a good core exercise?
Yeah, it's hard to really define anatomically the core because they're so interrelated, right? I mean, you can technically say your quads are part of your core because the rectus femoris attaches to your pelvis, and your
Yeah.
pelvis orientation has to do with your spine. Your latissimus is your core, comes from your armpit all the way down to the thoracolumbar fascia, which essentially attaches to every level of your lumbar spine. So it's hard to dissociate anatomically, but I think most people are referring to their abdominal muscles, the paraspinal muscles. And I think what was the second part of that? Like, what would we define a good core exercise, or how do we
Yeah.
determine that? Well, some general rules that I think apply to most anybody. Number one is pretty obvious. Rule number one I go by is, does the exercise challenge the intended target musculature? And in the way we want to challenge it. Are we seeking to have endurance or power? So that's one criterion. That's a pretty obvious one. Most people know what exercises challenge their core, planks, curl ups, prone, extensions or so on the ball. So second criterion is a little bit more nuanced. Does it put a disproportionate amount of stress on vulnerable parts of the spine? So the disc, the ligaments, the joints, the dura, these tissues can tolerate and adapt to stress, but not at the same rate in that same capacity as muscle or tendon. And that, I think, is a huge problem, a huge distinction. We tend to evaluate exercises based on maybe EMG exercise or studies. So somebody's reading something in Men's Health or in Self magazine or an online article saying to sit up on a ball with a weight has higher activation of the rectus femoris than any other exercise. So people say, well, that must be a great core exercise. Well, we also have to say, well, what is the proportion amount of stress that it puts on more vulnerable tissues like the disc, for example? We have some data from some of McGill's studies and others that show that there are relatively high loads with flexion-based loading activities. For example, a sit-up can put over 3,000 newtons of stress in a intervertebral disc. The Superman exercise, when you're laying on your stomach, you see this in Pilates a lot. You lift your legs and lift your arms up or so. That can put over 6,000 newtons of stress. A healthy, robust spine, maybe that's no big deal. But if you're 6-7 weeks out of a long battle with back issues and you're trying to get back into some things, I might consider that a disproportionate risk to the benefit. So that would be, and to give you an alternative solution, in that case, I would probably have them do more of a isometric cantilevered position over a ball, laying on their stomach over a ball, or in like a plank, for example, instead of a sit-up. The third rule I tend to go by is, does the activity teach you something? For example, if you're trying to learn how to minimize a lot of flexion so that you can do heavy lifts, like with your deadlift or lifting in your occupation, you don't want to necessarily do exercises that don't challenge that awareness. So a stiff leg deadlift would, maybe even a reverse hyperextension would, a plank certainly would. Those are exercises where you have to learn diligently how to maintain neutral spine position, as opposed to allow yourself to go into flexion like a curl up or a crunch would. So those are all relative to people's unique scenarios, but I find that if I abide by those three things, that helps me better delineate which exercise will be a good option for myself or my client or patient, and which ones may not be a great option.
And here's another question that I know there's probably been a lot of discussion in industry about is like how effective are like full body exercises at actually training your core muscles versus like assistance exercises, right? I'm thinking like a squat, a deadlift, a lunge, things like that that do require pretty substantial core activation, versus like crunches, leg lifts, like one arm farmers walks, like those types of things. Like what does the literature say on like, hey, if you want to strengthen your core, so to speak, which ones are more effective?
That is a great question, and the only evidence-based answer I can give you is we don't know. We don't have any evidence yet. They have done some studies where they've compared generalized strengthening with specific local strengthening, and they haven't found any convincing evidence. One theory as to why is that we are again going through the error that I mentioned at the very beginning of assuming that low back pain is homogeneous. There could likely be subclassifications of low back pain that would better be tolerant to or would respond better to a generalized exercise program versus ones that respond better to a stabilization based program. There is a such classification system that does show improvements. So, for example, if somebody has been shown to have hypermobility or instability based on a certain criterion of how they present, as well as exam findings, they tended to do better with core stabilization isolation exercises compared to general exercise. So there is some evidence that can guide us in that regard. So I think that's really comes down to seeing a clinician or an evidence-based clinician that can help delineate which rough category you follow in. So if you're somebody that has, chronic episodic back pain, it happens just spontaneously sometimes when you go to quickly reach or bend. Maybe you've been a gymnast or a dancer in the past. You might have some congenital laxity. You've had multiple ankle sprains. And then you present with a certain host of findings in exam. You tend to be those people that tend to do better with isolated stabilization exercise in addition to a general exercise program. Flipping it around, though, as a personal anecdotal answer, a response to it, I do mostly general strengthening, but I do find that in spite of being very strong, my endurance of my postural muscles is relatively poor. So doing years and years of deadlifting and pressing and chin-ups and walking lunges has not adequately allowed me to hold a plank as long as somebody who is far less in better shape than I. And that's really what McGill and some other studies have shown, is that endurance of the paraspinals and the abdominal muscles seems to be more correlated with a lack of back pain compared to strength. So in short, general exercise is probably going to be good for a majority of people for back pain. A certain subtype of people will probably need specific core exercise. And I do recommend for my clients and patients, even if they don't fit that subtype, that they at least do some endurance-based core exercise to complement their general strengthening based on the risk to reward ratio. You're likely going to reduce your risk by having better core endurance. And I can't think of a negative other than doing planks sucks and it's boring.
That's very true.
Right.
We do have a question from one of the listeners that's kind of along the whole topic we discussed today. Do you have any recommendations for someone with spinal stenosis and who wants to build muscle? And which cardio exercises can you recommend? Most of the PTs don't know.
Yeah, so spinal stenosis tends to, and again, this assumes that you're symptomatic and specifically you are intolerant of extension. Other than that, spinal stenosis, again, I have spinal stenosis. I was diagnosed at 17 with that at my neck. So
was that from a bunch of football injuries really early?
Yeah, it was acquired. They think it was acquired as opposed to congenital. But Doesn't, impact me horribly. But the point being is that most people that have stenosis that are symptomatic, it affects them later on in life in the 60s and beyond. I would recommend not doing, first of all, the things I tell you not to do is don't do things where you have to do a lot of hyperextension. And that is actually a relatively small menu of things. Prone hyperextensions would be the obvious one. Other exercises like deadlifts or any other things you choose, just don't get into the idea that you have to hyperextend and do a hard arc. Competition bench pressing, that probably won't bode well for you. Trying to get a hard arc, wouldn't be a good idea. Other than that, you really have just about anything, as long as you do it the proper way. So building muscle, go for it. There's really no limitations, I would tell you, other than those prior things. As far as cardio, I wouldn't tell you that anything would be problematic. If you have intolerance to load, then an impact, obviously running may be something that you have to minimize or change your distance, or do walk jogs. Elliptical should be fine. If you're really symptomatic and you're just starting out, I would tend to do a much shorter stride. If you can find an elliptical that allows you to do that. A longer stride tends to make it more likely that you'll hyperextend. And biking should be green light, go all out. I haven't seen anyone with stenosis ever have any problems with biking. So I would give it a yellow light on running, a yellow light on elliptical if there's a long stride, otherwise a green light, and then biking full green light. I couldn't find any limitation you should have based on stenosis.
Sweet. Any other topics you want to cover on, I guess, back problems or core strengthening?
Yeah, one quick thing. One strategy I've used to help people kind of communicate about what should I do, what should I not do. You ever heard of the Eisenhower matrix, Brad?
That sounds familiar, but I may have encountered it at some point, but I don't know exactly.
It's a neat decision-making tool where, if I'm interpreting it right, you make a quadrant, essentially a rectangle with 4 squares. And at the top you put, and in this context for like, should I squat and I have, back problems. And at the top you put high risk, low risk, so in your, horizontal, top. At the bottom of the more vertical part, next to the 2 squares, you put have to do / love to do, or don't have to do, don't love doing it. So to answer the question, let's imagine that you want to go into powerlifting, and loading your spine is something that's relatively high risk, but you love doing it. So you now are in the high risk but love to do it. In that quadrant, I put an M for modify. You love doing it, or you have to do it because your occupation requires you. Then you should be focusing on how to modify the squat, either externally or internally, how you do it or where the bar is placed, so that you reduce the risk. If it's something that's categorized as low risk and you have to do it, green light, don't even worry about it. If it's high risk and you don't love it or you don't have to do it, then avoid it. Minimize it. I find when you use those things, and I, just put responses in there, it helps you determine what's something good for me in my circumstance, as opposed to these arbitrary rules. Deadlifts are bad, squats are bad. You put that decision-making process into the factor, and if you don't feel qualified in being able to determine whether something's high or low risk relative for you, that's a great thing to ask your coach or, a clinician. If people aren't willing to speak to you in those terms, they tell you just simply what you can't do or what's bad, find another opinion. They either don't know the answer and trying to be definitive, or they're not giving you the full breadth of what I think you need.
Perfect. Well, it was awesome to have you back on. I know everybody missed you last week, so we'll be back on our regular 2-week program cycle from here on out. But again, thanks so much for your time, Mike. It was awesome to chat with you, and we'll touch base here in about 2 weeks.
Yeah, looking forward to it. It's always great being here.
All right. Take care.